Welcome to part 2 of the lecture series on corneal graft basics. In this section, we are covering endothelial keratoplasty. Before we begin, here is a recap of the learning objectives of the series. First, we take a look back at the evolution of endothelial keratoplasty. In 2004, Mellis et al. Described a method of posterior keratoplasty in which a lenticule of donor cornea was manually prepared or dissected, consisting of the posterior stroma, desiccae, and endothelium, and then it was inserted into the recipient eye. The recipient's desiccae membrane was also removed prior to implanting the new cornea, and this was termed desiccae stripping endothelial keratoplasty. The visual results following this procedure were good, achieving visual acuities of 20/30 or better. Initially, desiccae stripping endothelial keratoplasty was performed manually. Since then, donor corneas can also be prepared with a microkeratome or femtosecond laser, and hence is termed as automated endothelial keratoplasty. This also enables them to be prepared by the eye bank rather than the surgeon preoperatively, aiming for a lenticule thickness of about 100 to 150 microns. The advantages are that of a more consistent cut, reduced risk of donor perforation, and faster visual recovery, as the interface is smoother than that obtained with manual dissection. After preparation, the donor cornea can then be trephined to the desired diameter intraoperatively. There have been various devices and techniques described for DSAEK. These can be broadly divided into devices in which you push in the donor, such as the endosaver or the NCI, or pull-through devices, such as the Busin glide or the Tan endoglide, which we use here at the Singapore National Eye Centre. DSAEK is most commonly performed for Fuchs endothelial dystrophy and pseudophakic bullous keratopathy. Here we see a case of Fuchs endothelial dystrophy in which there is a characteristic bronze-beaten appearance of the endothelium with guttata more marked centrally. As the disease progresses, it can lead to corneal edema and reduced vision. This can be successfully managed with DSAEK, and we see here that the graft is well attached and the cornea is clear. The final visual outcome was about 6/12. Pseudophakic bullous keratopathy can follow complicated or even routine cataract surgery. In this case, we can appreciate that there is evidence of epithelial bullae and stromal scarring from chronic edema, with reduction in edema and scarring following successful DSAEK. So, what are the advantages of DSAEK over PK? Firstly, as the incisions are smaller, the eye is tectonically stronger. Also, epithelial problems such as poor epithelial healing are less common as there is less disruption to the ocular surface and corneal nerves. Fewer sutures also result in less induced astigmatism, and patients with DSAEK tend to have better vision as compared to patients who have undergone PK. The risk of graft rejection is also less in DSAEK as compared to PK, and recent results are showing that DSAEK has better graft survival as compared to PK. As a result of these advantages, there has been a rapid uptake of EK in the States. An eye bank report showed that in 2005, 4.5% of all cornea transplants were EKs, but this had increased dramatically to 44.9% by 2010. Some disadvantages of DSAEK include that of a learning curve. And in the initial learning period, there may be higher rates of graft dislocation or detachment, as high as 30%. Usually this is managed with intracameral air bubbling, but may come with complications such as pupillary block and high intraocular pressures. Also, there is an additional step of preparing the cornea tissue if the eye bank is unable to do so for the surgeon. Mellis has also described DMEK, or desiccae membrane endothelial keratoplasty, in which only the desiccae membrane and endothelium is transplanted through a small incision of 3 mm. Trypan blue has been used to visualize the graft in the eye. The advantages of DMEK over DSAEK are that of lower risk of graft rejection as even less tissue is transplanted, faster visual recovery, and better vision due to fewer interface issues. However, DMEK can be technically challenging, from harvesting an intact Descemet membrane with minimal endothelial damage to manipulating the graft within the eye. Graft dislocation and detachment rates can also be quite high in the initial learning curve. Also, it has been observed that endothelial cell loss can be higher than that seen in DSAEK. In summary, the last 10 to 20 years or so have seen a paradigm shift in corneal transplantation, with selective lamellar transplantation becoming the standard of care, aided by advances in surgical techniques, instrumentation, imaging, and technology. The advantages of lamellar keratoplasty over PK have also been established. We look forward to further advances to improve outcomes for our patients.